Sure. So the process we use is we look at, well, what is included in each of these different versions, and the respective committees within Congress that have been championing the management of the bills are, on the House side, are three different committees. They're Energy and Commerce, Ways and Means, and Education and Labor. And
which have nothing to do with health.
I guess there are different parts, the money, the labor, the commerce, and then on the Senate side is the Health, Education, Labor, and Pension, one committee.
That seems to be
or health,
more logical, yeah.
And then the Finance Committee. And so we've been afforded the opportunity to get breakdowns and summaries of each of the bills, and it allows us then to look at, well, what would actually be implementable here in Hawaii if we're thinking of how do we continue to make sure there's access to care? How do we ensure that our providers remain whole in the delivery of those services? And how do we look at opportunities to manage costs, whether it's through preventive means or those kinds of things? So again, for all of us, and again, it's a learning process for us as well, we're trying to keep up. But my understanding, what is sort of the next step, since the bill is still in flux and moving through Congress, is that on the House side, they're going to have to merge the three versions of the bill before bringing it before a floor vote. And then there may be additional amendments that are considered at that time. So as we all sort of hear this mid-September target that is being talked about in the public domain and on national TV, these are some of the markers along the way.
But Carl, since you've spoken primarily to procedural issues, why the rush on something so big? And now when you mention, well, there's three other versions that we've got to actually boil down to make one version. Why September? Why have we got to rush through September? How long has healthcare been around? How long has the Healthcare Association of Hawaii been around?
Since 1939.
Wow, okay. Decades upon decades. There's an emergency, yes, but is the emergency where you totally throw everything out with the bath? You throw the baby in the bath out to do it? And I just wonder, and again, let me confess, I wrote to Senator Noe what I said was, you know, if it's over 10 pages, the probability of reading it, the probability of understanding is very less. And these are the legislators who generally react that way. What about the American people? And I said, in effect, if that's the case, why don't we use what your body is usually called a deliberative body and take our time and break it up into pieces and make it understandable. So when you say, well, we got to put three bills together and we got to get it done by September, is that something that is compulsory, necessary? I mean, maybe I'm asking more for your opinion than what Washington says we got to do it by September. Why by September?
Sure. I think, at least from the providers that we represent, the things I can say assuredly now, obviously there are decisions being made by the president and at the federal level with respect to their priorities. For us, I would say that we do feel that, you know, reforming healthcare is something that is a priority.
Yes, I totally agree. It is a priority.
And I certainly understand what you're suggesting, in that it's a very large task to complete within a short period of time. So for us, our position is just that something does need to be done to reform the system. It's not sustainable on its current path if we look at just the federal funding mechanisms for it. How you go about it is certainly something we're hearing being discussed broadly. But
cool. Let's talk about that one. What is going at the federal level, which, Jay, I want to ask you for clarification and understanding. What is being stated is that we're going to cover more people for less money, and there's no rationing. That at elementary economics, or just more for less and no rationing? I don't get the logic of that. And again, this has nothing to do with political party.
Sure.
It has to do with simple common sense.
You know, and you know, it depends a lot on the way you define what rationing would be. I mean, what's happening now is that you know, we have a large segment of our population that's not covered. And so, but they get sick. I mean,
have you got numbers? How many?
You know, and I don't know offhand. I have to say, you probably do.
38, 40 million with some in transition, some down and out.
Yeah.
Probably a hardcore 18
it's about
million
1 in
that
6
really.
or 7 Americans.
Yeah.
So it's a large percentage, and they do get sick, and we know this happens. And so what happens when they get sick? They're going for the most expensive care because it's emergency room care, which is tremendously expensive. And so that's one of the big cost savings that you get with universal health care, is that people have access, are going to go to their primary care physician, which is a lot cheaper than seeing a specialist when you're in a critical condition. So there's a savings there. You're also looking at being evidence-based in your decisions on healthcare. Now, this is not rationing, but it is looking at, we spend a tremendous amount of healthcare dollars in the last 6 months of life, and we spend very little on prevention. And being a public health person, I'd really like us to see, spend a lot more money on ensuring that our populations are healthy throughout their entire life course, than concentrating it on, trying to increase life for a week or two with really bad quality of life in a lot of times. So it is trying. And I don't think we want to cut anybody off from healthcare, but we want to make rational choices in what we choose.
Part of that,
of
if
course,
I can say, should we love them any less because they're older and sicker? I know the president said there was a dilemma in his family's life when his grandmother took sick, but also fell down and broke her hip.
Yes.
And it was a matter of, well, should it be done? He didn't say how it got paid for, but she did get the hip replacement, and she did pass away within a matter of weeks.
Yeah.
But would that be something that, again, rationing would say, well, your age and all the probabilities point to we shouldn't do that? Now, those decisions are made at the personal family level, and if that gets relegated to government, I think there's probably a little bit of an ill-ease, if you will, among some of the American people.
Well, a lot of this already is. I mean, insurance covers what they cover, and different insurance companies decide what they're going to cover and what they're not going to cover. So, in effect, we already have rationing in some way. I mean, if you're in Kaiser and you're on the mainland and you decide to see a doctor that's not, in Kaiser, your coverage doesn't cover it. And so for people that travel, and for those of us who live in Hawaii that travel often outside the islands, you're looking at your healthcare coverage then. I mean, so I think there's always some sort of rationing. We can't say everybody's going to have everything covered all the time. It's not true now, and if I'm wrong, please tell me. And it won't be true under any plan.
I wanted her to tell you about the rationing of rationing. That is the Medicare reimbursement system that we're experiencing, in which the hospitals, the doctors are totally up in arms with, because evidently the bill takes back some of that Medicare reimbursement and spreads it more fully to cover those who are not covered. But what's the Medicare reimbursement state of the art now in Hawaii? Everybody in the last 2 sessions was up in arms about how that is unfair, not likely to meet anybody's satisfaction, and yet this whole system, if it becomes a universal single payer, Medicare becomes the healthcare system, and right now everybody's dissatisfied with it.
Just to build upon what was previously said, I think the important distinction is that single payer is one methodology of payment. Universal health care is a system of coverage. And so there is a recommendation in one of the House bills that benchmarks off of Medicare if there were to be a public option. But some of the other versions of the bill don't utilize Medicare as a benchmark, which is actually something that we prefer.
There is which bill is that?
In the Senate Finance Committee.
That's not the 3200, the one that's...
That's on the House side. Okay. So it carries the same name, but in the Senate Finance Committee, there's actually language in there that doesn't benchmark a public option off of the Medicare payment.